All right, we're going to do this morning is environmental emergencies. And this is a really, really fun topic. Covers all kinds of, actually a lot of the things that are in this talk are the reasons that we go into emergency medicine. And so we have time to do the sorts of things that are in this talk, like scuba diving, etc. The thing about this talk is it is very varied, so it's a broad range of things we're going to cover. So and we're going to do it pretty rapid fire. And to be frank, this is about 3% of your exam. So I don't want you wasting a ton of time studying this section, but there are certain things that they really like to test on, and I'll kind of clue you in on those things as we go through it. But this is an area that they will mine for a few questions that might freak you out a little, and hopefully they won't. That's what we're going to review and sort of focus on here. But please, when you get down to your studying, if you're kind of a last-minute studier, don't focus a ton of time on this section. Really focus on things that they do a lot of testing on, like cardiology and trauma, etc. So that's just sort of a disclaimer before we get started. So let's get going. Let's start with water-related things. So we're going to start with drowning. There was a fabulous article in the LLSA section, for those of you who have done your research on drowning, that was recently done. This is going to focus on the kind of things that are sort of more standard things that are in the textbooks about drowning. So the reality is, I love this slide. This is absolutely true. Nowadays, if something terrible happens, people tend to take out their cell phones before they actually act on anything. But when it comes to drowning, we have certain definitions you need to understand. Non-fatal drowning is basically the process of drowning that gets interrupted. You don't die. Versus fatal drowning, where you actually, it's a done deal. You drown. A water rescue is kind of a new-ish term that sort of it stands for what we used to be calling near drowning. We don't use near drowning anymore. Basically, water rescue is you're under the water, you're immersed, but there's nothing that happened to you. You just were under there for a while. You didn't have anything that was started the drowning process. So this is the kid that falls in the water, is under for 10 seconds. You reach in and you pluck him out of the water. That's a water rescue. Or somebody who's flailing around in the water, but they aren't under for any amount of time. That's a water rescue. If you're under for an amount of time where you may have aspirated some or had some damage from drowning, that's basically the non-fatal drowning, and then fatal drowning is sort of self-evident. Who gets this? Well, it is children, okay? It's children. There are kids who basically end up in pools, end up in bathtubs, in little buckets of water. We know kids can drown in an inch of water. So young kids are a large majority of these, and then stupid teenagers and adults that do dumb stuff. Drink and swim, jump off 30-foot roofs into pools and swim. Those are the sort of people that tend to drown. It's not any other groups of any significant proportion. It tends to be those two in this significantly leading group of people who drown. Now, when you get into the water, what happens is your mammalian diving reflex kicks in. So if you go under the water, what happens is your body sort of shuts down. Your heart rate slows down, you stop breathing, you shunt the blood to your central nervous system to try to keep your brain alive while you're under the water until things can either you get back up into the air. It's a way to try to keep you alive while you're underwater. Your metabolism slows down, and kids have a much more powerful diving reflex than do adults, which is why children underwater can survive better than adults who are underwater for the same amount of time they're underwater. Kids have a much higher survival rate with good neurologic function. If someone is shocky, so say they give you a test question where they say, 18-year-old male found on the bottom of the deep end of a swimming pool, or 18-year-old male found in the ocean, that's probably even better, found in the ocean, pulled to the ocean out of the water sounds like a drowning, except that his blood pressure is 60/40. That is not from drowning. Okay, shock does not happen in drowning. So if that's the case, you're going to be looking for trauma. So maybe he fell out of a boat and he has some sort of trauma that caused that. It's not from the drowning itself. So that's one thing that's crucial. So trauma has to be ruled out. Hypotension is not from drowning. And C-spine precautions are not routine in somebody who is found in water. However, if they give you a question where somebody's not in C-spine precautions and they are found where they might have been on a diving board, or they may have been in a multiple trauma incident where they fell out of a boat, that's the kind of thing they're going to want you to put somebody in C-spine precautions. It is not something that has to be routinely done, though. So a little kid who just slips and falls in the pool, it's a witnessed event, doesn't have to be done in C-spine precautions. And the take-home message on salt versus fresh water, as far as somebody who drowns in salt versus fresh water, it turns out that there's no significant survival difference in those two groups. There's a lot that gets sort of talked about theoretically, that if it's salt water versus fresh water, there's osmotic issues that are a problem. If it's fresh water that's really gunky, there may be infection, and that turns out to be true. But overall survival, fresh versus salt, is not significantly different. And that's not something I think they'll hit you with on the exam. Now, who drowns? Who dies from drowning? Well, all of this makes logical sense. How long you're underwater makes a difference. What happens to you when they pull you out? How old you are, if you're a kid versus an adult. A lot of those things make a difference on what your survival likelihood is if you're a drowning victim. And not everybody needs admission. So one of the things that I think will maybe infiltrate itself into the exam is if you have somebody who basically is a non-fatal drowning, okay, they're a water rescue or a non-fatal drowning, and they come to see you, and they have that person in the ER. If they have no RALs, if their SATs are good, if there's otherwise no reason to admit them, they're not tachypnic, etc., they're looking great, that person can go home. There's no need to OBS that person. So that person can actually be discharged. And that is something that's sort of a little bit of a difference. We used to at least keep people around for a while. It turns out those people do just fine. So just know that there are certain people who will be brought in as near drownings, which is the wrong term right now, it's a non-fatal drowning, that you may be able to discharge. So just add that to your sort of list of things. That's somebody who may actually, the right answer would be to send them home. Now, when it comes to other things related to swimming, I love this. This is a card a friend sent me, the New England Journal of Medicine swimsuit issue. This is all the doctors and nurses in their swimsuits. I think this is hilarious. Let's talk about scuba, because if you can't breathe underwater, but you want to stay under there for a long time, a lot of us will take our air with us. The boards really love scuba diving questions. They're complicated. How many of you are certified divers? So those of you who are certified divers know more about this topic than you need to know for the exam, I will tell you, because you had to know that because you don't want to die down there. But they really like some questions based on this. And what they tend to like are questions where you understand disorders of descent and ascent. So let's get into this. Certain people shouldn't be divers in the first place. Just so you know, if you're an asthmatic, especially a bad one, you probably shouldn't be under the water. If you have a bad cold, you probably shouldn't be diving. If you have panic disorder, it just makes no sense to go 60 feet underwater with a panic disorder. Not a good idea. Certain people shouldn't be divers. But and it's awesome, I think diving is amazing. If you dive, there are certain things you have to understand about the interface between the gases in your body and the liquid of yourself. You are a liquid thing, basically. You are walking water with some gassy spaces inside you. And what happens to gases and that interface under pressure? There are three laws of physics, physiology, basically, F-I-Z-Z-Y-ology, that relate to diving. One is Henry's law. And basically this says the amount of gas that's in a liquid, so you have a gas-liquid interface. And now you put the system under pressure. The amount of gas that goes into that liquid is proportionate to the pressure of that gas. So as I'm going underwater, and I have a gas-liquid interface, so my lung-blood interface, as this pressure increases, I'm going to get more of the gas pushed into my liquid, into me. That's fine. Dalton's law says the gas in and of itself, that gas portion as I go down under pressure, gets an increased partial pressure because it's down under a lot of pressure. So I have more pressure in that gas and more of it wants to go into my liquid state as I go down. Okay, those are those two laws. The other is Boyle's law. Boyle's law says that the actual volume of gas, not just how many particles there are, the partial pressure in that gas, but the volume of that gas gets compressed as you go down. Okay, the more pressure on it, that volume will get compressed. And as you come up, it will expand. Anyone who's done a diving course, if you've actually done a hyperbaric course, they do some wonderful experiments where they'll take a 20-ounce styrofoam cup in with you when you go into a dive chamber. So you have this beautiful, tall styrofoam venti cup that's sitting there, and as it goes, it's full of all these little air spaces, right? That's how styrofoam is made, all these little air spaces. You put it in a dive chamber and you dive it to depth. So it goes down to what would be 1 or 2 atmospheres of pressure. You go down, dive it to depth. That cup ends up about the size of an 8-ounce cup because all of those air spaces get compressed because Boyle's law says those air spaces get smaller and the cup literally gets smaller. It's an amazing sort of way to show you very vividly what's happening to the gas in your guts, the gas in your sinuses, the gas in your lungs. And the reverse, that cup doesn't expand on the way up just because styrofoam won't do that, but you do as you come to the surface. So these three laws are very integral to the things that can happen to you bad when you go down underwater. So the squeeze syndromes, these are disorders of descent. This is a closed airspace. Sinuses are a very common one. So is your mask, right? You stick the mask on your face. That's a closed, fixed space that has gas in it. As you go down, that space gets smaller, right? That's Boyle's law. That amount of gas gets smaller. You get a lot of pain from that. You get a lot of pain in your sinuses. You can get what's called mask squeeze, sinus squeeze, where everything's getting smaller. The way to fix that is to equalize the pressure. That's where you actually blow a little bit of air into your mask. So you now add a little bit of air to that so that doesn't squeeze onto your face. One of the times I went diving, somebody didn't do that. And they basically had masks. I don't know how they even stayed underwater that long, but they had underwater long enough that when they came up and took their mask off, they had this ginormous hickey about this. It was this huge hickey right here from basically getting mask squeeze. So you fix that by adding some air to that or blowing into your own sinuses to basically equalize the squeeze. These are disorders of descent. The gases are getting smaller. Okay, these are the squeeze syndromes. They can get bad. If you don't equalize, you can rupture your TM. And if you end up with a cold rush of air into your ear when you're underwater, you get vertigo. It's a disaster. It's actually a mess. So there are ways to fix this. Those are the squeeze syndromes going down. Lots of different kinds. And just think of any fixed airspace that can happen. It's most common in the sinuses and in the mask. You can also, if you have cerumen, if you basically haven't cleaned your ears for 35 years, and now you go down underwater and there's a little pocket of air between the cerumen that's jammed in your canal and your eardrum, you can get that as well. And inner ear barotrauma can also occur, where that causes some pretty profound, if you rupture your oval window, it causes some pretty profound vertigo. So these are all squeeze syndromes, and they are disorders of descent. The gas-filled spaces are getting smaller and smaller and smaller, and unless I add some sort of air to that, some sort of gas to that, it's going to become a problem. Ascent disorder, those don't kill you. Okay, ascent disorders will kill you. So this is now the gas when I'm down at 60 feet. It's all been smushed for a while, and I decide I see a shark, and I freak out, and I bolt to the surface. Or I drop my weight belt. It falls off, and suddenly I can't stay down there anymore, and I go zipping to the surface. If I keep my glottis closed, what can happen is the air in my lungs expands. It gets bigger and bigger and bigger and bigger. And it can cause me to have a pneumothorax. It can pop. I can get a pneumomediastinum. I can get a pneumothorax. It's a burst lung. And that's one of the reasons as you ascend, I love this when you're diving. You're down there at depth. You kind of float up 10 feet. You don't have to do anything. And you feel the air coming out of your lungs if you keep your glottis open. It's really cool. It's really awesome. It's kind of amazing. But if you don't do that, you'll get a pneumothorax. You'll pop. Basically, this is burst lung. This is the pulmonary overpressurization syndrome. Makes complete sense why it happens, right? My gas-filled space expands in size as I'm ascending way too quickly. The way to prevent that is to exhale on your way up. Then that extra gas gets out into you breathe it out into the water, and it's all good. They come in with pneumomediastinum and pneumothorax, and this is a pretty obvious thing when they come to the surface. It's pretty bad. What can happen worse than that, though, is if I really have closed down my glottis, I'm coming up too fast. Not only do I rupture a lung, I can get basically pulmonary or air gas embolism, arterial. This goes right into my arterial system, and I get an embolic phenomenon. This is a rapid and sudden change, and it causes all kinds of things that can happen, but mainly neurologic. So I end up with coronary problem. Just think about where air bubbles can go. It's that thing that when we're doing IVs and we start IVs in people, we freak out that, oh, there's a little bit of air that gets in there. That's not the problem. This is a significant amount of air in your arterial system. It can go to your gut. It can go to your head. It can go to your coronaries. It can cause a lot of syndromes, and it's fast, sudden and dramatic changes, usually within 10 minutes of hitting the surface, if not the minute you hit the surface. So if you have an exam, if you're not a diver, and this is all just, I hate this stuff, kind of stuff to you, if they have somebody who has a sudden event at the surface, they want you to think air embolism. They want you to think arterial air embolism, that they actually came up too fast and popped something into their bloodstream and have an arterial air embolism. This is often altered level of consciousness. They can seize. They're usually really sick. So that's a sudden event at ascent while they're coming up. There is a disorder at depth. Any of you have taken a hyperbaric chamber course, one of the things they do as well is they take you down there with puzzles or games or cards. They'll take you down with a deck of cards. And they dive you to death. And what's happening is my partial pressure of nitrogen in my lungs increases because I'm down at depth. And it also wants to get into my bloodstream more aggressively because at depth, that interface pushes the gas into my bloodstream. One of the gases you don't really want in your bloodstream is nitrogen because it makes you wacky. It makes you wacky. So if you're in a dive chamber when they're doing these dive courses and you're playing cards, all of a sudden you're making mistakes. And if you YouTube nitrogen narcosis videos, they'll show people sitting in these chambers together, and someone will just slide out of their chair and go onto the floor because they go basically comatose. Imagine doing that at depth. You're down, and you start to do wacky things. You take your belt off, you have poor judgment, you do really dumb stuff, at a depth where you can actually die from it. That's nitrogen narcosis. So it's a combination of Dalton's law and Henry's law that gets just too much nitrogen into you. And when that happens at depth, it makes you kind of wacky. Okay, so it's a danger because you do stupid stuff at depth. The treatment for that is to come up slowly. That's what your dive tables are for. If I'm down at 60 feet for whatever number of minutes, my dive table says, on my way up, I stop at a level and I breathe for a while to let it come out of my bloodstream or out of my water part of me into my lung part of me, my gas part of me, and I exhale it out. And it does that gradually as you come up in steps. If you don't do that, you end up with some of it stuck in the wrong place, which causes another disorder, which is decompression sickness. What happens is, if I don't come up at my stepwise approach, I now have nitrogen trapped in certain parts of my body. And it goes all over the place. And it can cause syndromes that are anything from minor, where it's problems in your skin and your joints. Okay, that's decompression sickness type 1. Or you can end up with the big deal, where you end up with problems with your CNS. So this is basically you come up too quick to let all the nitrogen kind of work its way out of the water part of you into the gas part of you out into the atmosphere. You end up coming up too quickly. So you trap the nitrogen in your system. Decompression sickness type 1 is the bends. People will end up with basically a change in their skin that looks like marble. Okay, their skin gets kind of whitish looking and marbly looking, and they have lots of joint aches and pains. It's called Caisson's disease because when they built the Brooklyn Bridge, they built it with people in this big, huge caisson, this big thing underwater, and they would spend all day down there in this big box building things when they were building the Brooklyn Bridge. But when they came to the surface, they got brought up to the surface at the end of the day. They had way too much nitrogen in their system because they'd been working down there for hours in this box full of air, but they were at pressure. They ended up with too much nitrogen in their system. It's called Caisson's disease. Fascinating. They learned a lot about the bends from the guys that built the Brooklyn Bridge. It's itchy. Your skin is red. It can be white and mottled looking. You have lots of aches and pains. This is basically from little nitrogen bubbles in your skin, in your joints, causes a lot of discomfort. Decompression sickness type 2, though, takes it to a whole new level. This is central nervous system. And because if you think about what's happening, instead of just an air embolism where I've now thrown it to my coronaries, that's an abrupt thing. That's the overpressurization syndrome. This is different. This is bubbles that are trapped now in my CNS. They're trapped in my core. They're trapped in my brain. And people end up with neurologic stuff, but not right away. It tends to take several hours to really fully develop. So if they give you a question with someone with altered level of consciousness or something neurologic, but it is hours after they come to the surface, not minutes after they come to the surface, they want you to think about decompression sickness. That's what they want you to focus on. And common symptoms are things like dysesthesias. My fingers are numb, my right leg is numb, it's dysesthesias. They can be altered, but this tends to be more the dysesthesia, is sort of altered judgment kind of thing. True altered level of consciousness is rare. So the person who comes to the surface and is out cold, that's probably an air embolism. This is somebody whose judgment is off. They're just a little off. Basically, these are gradually developing symptoms, and the physiology makes sense of why that occurs. So, and there's other sort of versions of the decompression sickness, but those are the two big ones, type 1 and type 2. There are a few other ascent disorders that I don't think will end up on the exam. These are sort of more just for completeness. You can have tooth issues. You can fart a lot. Don't eat cucumbers or drink beer before you dive because that gas in your guts gets squished at depth, and as you come to the surface and you end up with a big bubble here under your wetsuit because it all has to come out somewhere. So it's basically, that's a flatulence syndrome. That can occur as well. Just know all of the main ones are the decompression sickness, the embolic phenomenon, and things like the pneumothorax. This is a summary chart. If all of this is like, God, I just can't remember all this jazz, this is a summary chart. The things that happen on ascent are pulmonary overpressurization syndrome, the pneumothorax, air embolism, which is sudden, decompression illness, which is gradual. Disorders that happen either at depth or during descent are the squeeze syndromes and nitrogen narcosis. So that's a little summary, sort of putting them all together. What they're going to want you to answer most of the time is put them in a chamber. So if the question is somebody that has pulmonary problems, is altered level of consciousness, has numbness and tingling in their fingers, they're a little bit, sort of their judgment is off, they're going to want you to dive the person. Have a low threshold in anything you think is a decompression sickness illness to put them in a chamber. Okay, that's sort of the bottom line question answer they're going to want from you when they put out a SCUBA question to you. That's usually what they want you to do. And they also know one of the things they kind of like to ask about is, can somebody come in 3 days later and have decompression sickness symptoms? The answer is yes. And theoretically, you can dive someone and have them improve for as long as 14 days after the diving episode. So you have a pretty big window to get this done. One other thing to know, and this is actually, I live in Southern California. We don't have too many diving stuff there, but we do, because it's cold. It's cold in the Pacific. People diving, you have to kind of really gear up for it. But we do get people that come from elsewhere with diving. And we had a woman with decompression sickness type 1 who had been in the Caribbean, had been diving like crazy, didn't get any symptoms until she flew. And what happened when she flew was she ended up at altitude. She ended up basically like she was in Denver. And that same gas phenomenon, there's less pressure, okay, you're at higher altitude, there's less pressure. She ended up with decompression sickness at altitude and came to the ER because she said, man, my skin was so itchy and I was so achy at altitude. I feel a little better now down here at sea level, but I'm still having some symptoms. She basically had given herself decompression sickness type 1 because she had dove too much. The last day didn't give herself enough time to get rid of all that nitrogen and got herself symptomatic at altitude. That's why it's really not recommended to dive the day you fly, or at least dive twice for sure the day you fly, because you can end up with decompression sickness, especially if you don't come to depth, come up slowly when you come up on your dive table. So this is sort of the recommendation. Now, one sort of sidelight that goes with these pressure phenomenon as far as what happens to gases is basically blast injuries. And it's the same idea, it's just faster. So if you have an explosion, the changes in gas pressure are sudden, abrupt, and massive. So gas-filled structures are the ones at risk in people that are near a blast injury. So TMs are a big one, lungs are another. So no blast injuries, it's air-filled structures. Your guts too, but mainly it's lungs and ears that are a problem as far as the pressure event that happens with the blast. So that's just a little sidelight. All right, let's get to altitude. Okay, so instead of flying, this is actually a baseball. My husband used to live in Colorado. We had a 10-year relationship of long distance. He was there and I was in California. This is a baseball cap that you can buy when you're at altitude in some of the parks in Colorado. Because if you've ever tried to go hiking, I don't care what good a shape you're in, if you ever tried to climb a 14er, and it is really hard to do it because there's just no oxygen up there. Let's talk about high altitude illness. Basically what happens is, if you are used to living at sea level, and then you schlep yourself up to Aspen because you're going to go skiing, you're going to do your Aspen Highlands skiing, you're going to go up to 12,000 feet. What happens is there isn't a lot of oxygen up there, and your body tries to overcompensate. So you get a hypoxia-induced overperfusion syndrome. You basically, your heart rate goes up, you try to perfuse, because there's less oxygen in your blood, so your heart goes a little crazy, saying, let's circulate what we have, let's get it to where it needs to go. And you get increased sympathetic activity as well. And for most people, that's not a big deal. You're a little bit uncomfortable, but it's not a big deal. For some people, that becomes an enormous problem. The range of problems is anything from acute mountain sickness, and I guarantee half of you in this room, if you've gone to altitude, have had this. You may not have recognized it, but I guarantee you've had it. It can get to something really severe like high altitude cerebral edema or high altitude pulmonary edema. There are eye problems that can occur, and choose your tent mate carefully if you go camping at altitude, because there is such a thing as high altitude flatulence expulsion syndrome. It's a truly described syndrome, I kid you not. So as you go to altitude, that person who's got a lot of air in their guts will have to let it loose at some point in time. Same thing as diving and coming to the surface. So flatulence can become a problem. How you get this depends on several things. If you gradually go, if you're a climber, if you're one of these people in this room who really, really does the high climbing, there's a reason that you actually climb and then stop. And not only stop, you climb and then go back down a little bit to sleep. And then you climb the next day up and you go back down a little bit to sleep. That gives your body a chance to acclimatize to altitude. If you decide to skip all that and you go from Los Angeles to Aspen Highlands, you have no adjustment time there. So you increase your risk of having these syndromes. It turns out certain physiology protects you and certain physiology doesn't. We'll get into that in a second. And sleeping at altitude, the reason the big time climbers come down a little bit is it gives your body a better chance to acclimatize. Sleeping at that high altitude turns out to be a factor in developing these illnesses. If you've had it before, odds are you're going to get it again. It's unfortunate. So if you happen to be a super jock who loves to ski, but every time you go to altitude, you get a gnarly headache, tachycardia, and if you've ever had one of the big syndromes, you just don't go back. Okay, find another sport to do because the risk is just really high. And if you live at sea level, if you live low, you're just more likely because you're not adapted at all to altitude if you live down at a low level. Certain people with heart disease shouldn't be going to altitude, particularly people with shunts. Just don't do it. People who have a right to left shunt should never go to altitude. They shouldn't even go to Denver. I mean, it's bad news for that. And it turns out you can be the biggest jock in the world and you're not protected from developing altitude illness, which is really frustrating. If you're a super jock and you are a marathoner and a taekwondo person, but you want to ski and you get altitude illness, being super jock doesn't protect you. It turns out, though, that if you are a female who's a little bit heavy set and you're over 50, you are less likely to develop acute mountain sickness. I'm there, it's good, I'm going to altitude. So it turns out you're less likely to get that. Now, let's go through the range of symptoms. I want you to remember the last time you went camping at altitude or skiing at altitude and you basically woke up day 2 and it's like, man, that one glass of wine or that hot toddy after skiing, wow, I'm really having a hangover from that one glass of wine. No, you're not. You're having acute mountain sickness. Acute mountain sickness basically is headache, nausea, tachycardia, tired, you can't sleep, you feel a little sick. That is acute mountain sickness. Your body, and nobody really knows exactly what's happening in there, why this happens. Truly, if someone says they totally understand the physiology, nobody really does. They've all tried, they just don't know. But they do know certain things tend to help. So if you know you're an acute mountain sickness kind of person, you can prevent it, or at least ameliorate it, with using something like acetazolamide or nonsteroidals. Either answer would be right for an exam. Either one is fine for real life. So taking something like a nonsteroidal the day you travel and the day after can ameliorate the symptoms. Acetazolamide is fine. Okay, we don't know how it works. We know that basically it causes bicarbonate diuresis, makes you metabolically acidotic and increases your respiratory rate. It's not clear that that is what fixes it. We just do know that it makes people a little bit better when they have acute mountain sickness. It also, though, I just want to warn you, if you take it, it gives you tingling in your fingertips because it alters your ionized calcium level, so you often will get tingling in your fingertips and toes, be aware. And the other thing is carbonated beverages tend to taste ghastly if you're taking acetazolamide. So your beer, your sodas tend to taste awful, just as a warning, just know that that occurs. Now, that's if day 1, usually most of us, when that happens, with meds or no, it tends to just go away. By the end of day 2, morning of day 3, you're starting to feel better. What can happen, though, if you're unfortunate, is the beginning of, so I got there on Monday night. Tuesday morning, I had a pretty bad headache, and I wasn't feeling very good. I kind of tired, and I felt my tachycardic, but I'm going to ski anyway, damn it. Wednesday morning, I get up. I'm carrying my skis across the parking lot, and I flippin' cannot breathe. I cannot breathe. I just walking 25 feet, I'm having trouble. And my friend, doctor friend who's traveling with me, puts their ear on my back and says, dude, you've got RALs. What's the story? What you've developed is high altitude pulmonary edema. It is the real deal. It is flat out alveolar fluid. It's not from heart failure. It's a leak. It's a direct leak in your lungs. People can get febrile. They look like somebody's in pulmonary edema. This is a big deal. Okay, this is a big deal. If they don't correct their oxygenation with some oxygen within 10 minutes of getting to a medical facility, they need to be taken down. They need to be descended, taken down off the mountain and down to a lower altitude. Really, really important. This is a big deal problem. People can die from this. Your heart size is normal. Again, it's not a cardiogenic pulmonary, it's non-cardiogenic. And these people need to get down. If you can't get them reoxygenated, they've got to take them down. And so on an exam question, that's something that would be in your list of options. Descend the patient or put him in a bag. We'll talk about that in a second. Get him down to depth, get him off the altitude level, either by doing it artificially in a chamber or actually taking them down off the mountain. So that's key. This is what it looks like. There's other things that cause it, but no, high altitude pulmonary edema is in the differential of small heart, obvious pulmonary edema. The treatment of this, I mentioned, is oxygenation, but honestly, if somebody is not reversible, what you're going to do is either drive them down the mountain, get them in a car and get them out of there, or put them in a chamber. And a lot of the places that are up at altitude have either dive chambers, hyperbaric chambers, where they'll put you down, they'll get you down to more like sea level, or they have a thing called a gammo bag, which is awesome. If you go really out in nowhere at altitude, you're out hiking in the middle of nowhere, there's a thing called a gammo bag, which basically looks like it puts a person in it, and it looks like a big capsule that you basically pressurize. You put somebody in there, and you pump it up to pressure, and you basically are technically diving them. I'm so sorry about this. I'm going to move it down a little. Sorry about that. You're diving them, but it decreases the problem of the pulmonary edema. Now, let's say instead, you've had your episode of acute mountain sickness on day 1, you're fine, you're with your buddy, you're skiing, but day 2, you get up to the top of the mountain and your friend does really bizarre stuff. Your friend's a super awesome skier, but he's skiing off the path. What is the story? He tries to put his ski on backwards. He starts to walk and he's walking like a drunken sailor. We weren't drinking this morning. That is high altitude cerebral edema. Usually, and this is deadly. This person, if somebody has altered mental status or altered judgment, they're ataxic, they're confused, they're vomiting, they may truly go on to seizures and coma, that person gets down off the mountain right now. Right now. This definitive treatment is descent. Everything else you do is a Band-Aid. These people need to get taken down. I used to teach conferences up at the ski resorts, and we had one conference where one of the people in the conference got absolutely clear-cut high-altitude cerebral edema, got stuck in a car, and from really confused ataxic, got stuck in a car, and literally just driving them down in Colorado from basically Aspen down to Denver, in the drive became completely normal. During the drive, just the change in altitude from 11 to 12,000 feet to 5,000 feet got that, and usually you'll need to drop them by 1,000 to 2,000 feet and they will get better. So it's really important in these cases in particular, get them down, descend them, crucial, crucial, crucial. Let's switch topics a smidge and up at altitude while we're skiing. Instead of worrying about altitude illness, let's talk about hypothermia. Let's talk about what happens when you get cold. This is basically, a lot of things can cause you can get hypothermic in Las Vegas, theoretically. A little tough to do, but you can do it basically where you have basically too much heat loss. Okay, that's the problem with this. You get hypothermic, too much heat loss. Most of your in fact, yesterday someone was complaining about how cold it was in here. It was freezing in here yesterday. I mean, you're getting technically hypothermic in here because you have all this skin surface surrounded by, that is at 98.6 degrees, surrounded by a room air that's 68 degrees. You're losing all of this skin surface out into this cold air. Well, now you take that skin surface and you put it under cold water, or you take that skin surface and put it out in, minus 50 degree weather, you can get hypothermia, no question. So there's lots of ways that can happen. It can also happen if you're wet and there's wind, it can happen. If you're wet and there's wind and it's cold, it can happen in a heartbeat. So there's lots of ways that you actually get cold. We define hypothermia as a core temp of less than 35 degrees. And you know that people get hypothermic, not just from exposure. We're going to be talking about environmental causes, but sepsis can do it as well, hypothyroidism can do it, lots of things can cause this. Hypothermia, though, is what we're focusing on here that's related to the environment, and it's a temperature less than 35 degrees. From 32 to 35 degrees, your body tries to fix things. So you shiver like crazy, okay? You know to try to find something that's warm to wrap up in. But at 32 degrees, everything slows down. You lose your ability to generate thermogenesis with shivering because you just can't shiver at 32 degrees. It just doesn't work anymore. Your body starts to shut down. Things slow down. You decrease your oxygen utilization. Think about your hemoglobin oxygenation dissociation curve. Not only in there is the amount of oxygen, but in there as well is temperature. When you're cold, your hemoglobin hangs on to oxygen like crazy. It really, really wants to hang on to it to keep oxygen in your system. The risk factors of people getting hypothermic are obvious. Somebody who's young who can't get out of the cold, somebody who's old who can't get out of the cold, somebody who is altered, they're a little crazy, they're a little drunk. Those people, the coldest person I've ever seen in my career, I work in Southern California, coldest person I ever saw in my career was in San Francisco in June. I have actually one of our graduates is here. She works in San Francisco. And if you were in San Francisco in June, it is bloody flippin' cold. It is foggy, it is windy, it is cold. This is somebody who was blitz drunk in Golden Gate Park under a tree in June. The tree collected all kinds of that fog that was drifting through, dripped it all over this guy, and it was windy like crazy, and it was, it was cold in San Francisco, 60 degrees. He came with a core temperature of 79 degrees in June in San Francisco. This can happen to anybody, okay, absolutely anybody. So he was at absolute risk factor for it in a place where you wouldn't necessarily think about it. So no, it's not just Minnesota that gets hypothermia. It can be just about anywhere. Now there's certain concepts that they like to test on that, I will be frank, are probably in real life not that big a deal. So paradoxical core afterdrop. The theory of this is, I am a 70 kilo person with a blood volume of 70 cc's per kilo that is sitting at 32 degrees. I'm cold. You decide to wrap me in something hot. So the surface of my body gets warm, and the blood that's at the surface of my body warms up. But the problem is that all the rest of the blood that's still cold gets shunted to the surface. My skin gets warm, I vasodilate there, everything kind of hangs out there, but all the rest of the stuff gets shunted to the core. That's called paradoxical core afterdrop. The reality is it probably doesn't happen. Physiologically, it makes some sense. In reality, it probably is not a problem, but it's something, especially for the qualifying exam, they may try to throw out there. I wouldn't spend a lot of time on it. Hunter's response occurs, and those of you who hunt, especially if you hunt in the winter, you have probably had this happen. Your hands turn out to be a very important sort of sensor for your body to know what to do about heat and cold. And one of the reasons if you're hunting in the cold, or if you're out in the cold at all, is you want to keep your hands warm, is your body makes certain sort of responses based on how hot or cold your hands are. What you'll end up with is if your hands get really cold, you get a thing called cold-induced vasodilation. God knows why, but it absolutely occurs. And what it makes you feel like is it feels like you're hot. Okay, I have all my blood at my surface. I'm dressed in multiple layers because I'm supposed to be, because it's 40 degrees outside and I'm hunting. But I'm feeling kind of hot. So you do this paradoxical undressing thing. That's basically a hunter's response, or it's basically cold-induced vasodilation. It's a weird phenomenon. It's based mainly on your hands, so keep your hands covered in this. And anyone who has gone camping where it's cold knows you would get this particular next problem, which is cold-induced diuresis. When you are cold, your kidneys hyperfunction. Okay, they produce a lot of urine. So if you're camping and it's cold outside, and you're having a grand old time, everyone has to get up and pee at 2 in the morning. Right? Everyone does. Think about it when you've been camping in the cold. It's like, why? I didn't drink that much. What's the story? Everyone does it. And it's a drag because it's cold outside and you have to get out of your warm, sleeping bag and go out there. But that's cold-induced diuresis. It's a physiologic thing. God knows why it happens. If someone is cold, couple things that you need to know about. Their coagulopathy goes crazy. Okay, they get coagulopathic. That gets better, by the way, as you warm them up. But at cold, it's temperature dependent. And we do that with trauma patients, right? We keep them warm because we don't want them to get cool and have their coagulation not work very well. Their glucose gets all off base. Their shivering depends on where they are in the spectrum. Their oxyhemoglobin dissociation curve shifts, so they don't use oxygen as well as they should. And volume resuscitation, if you need to, they often don't need a lot. They may be hypotensive, but it's not because they've lost a lot of fluids. It's basically because they need to get some vasoconstriction out there to get their blood pressure up. So they don't need a lot of fluid in this case. And they end up with a lot of pulmonary problems, all this list of things you can sort of look at. But what they love to test about is the Osborne J-wave. I guarantee either the concert first of all, I can't guarantee. I suspect that either the concert or the qualifying exam will have a question along the lines of, they'll give you in your lovely pictorial book or your pictorial computer thing, they'll show you an EKG that will show this really funny kind of squiggle at the J point. And they'll say, you were presented with a patient who has this EKG. Which of the following do you want to do first? And it will say, what it'll be is a bradycardic patient with a little funny squiggle on their EKG right at the J point. And they're going to say, give atropine, transcutaneously pace, give amiodarone, check a core temperature, check the patient's meds list. What they're going to show you is an EKG like this, and what they're wanting you to recognize is that that's an Osborne J-wave, that little bloop that you see there at V2, that is not something that is electrolyte based, that's not something, that is basically somebody who is hypothermic. And that will go away when you get their temperature up. But they love to ask questions based on the Osborne J-wave, and they often ask them backwards based on showing you this and wanting you to recognize that it's a temperature you want to know in that patient, that you don't want to treat this specifically if they're otherwise stable. Okay, you don't want to treat this specifically. And here's just another version of it. Basically, this is a hypothermic change that goes away when you warm somebody up. Now, if somebody codes and they're cold, this is a big dilemma for us. Okay, this is a big problem for this. If they actually have a cardiac arrest, most drugs that we use don't work very well at low temperatures. So you could fill them to the brim with amiodarone, it's not going to work. It doesn't work very well. And cardioversion actually doesn't work very well. If somebody's in a VFib arrest, it just doesn't, your heart's not very responsive to that when they're really cold. What you really need to do if someone is in cardiac arrest is do CPR. If it's a shockable rhythm, give them 1. If they get a response back, great. If they don't, continue CPR and warm them. It's not recommended to really try much more until you get their core temperature up by a degree or 2 from where they started and then give it a go. But the reality is it's really tough when somebody's cold and in an arrest to get them resuscitated until you get them warm. So do your best to do great CPR, get them warm the best you possibly can, and then go ahead and try the drugs, etc. They just don't work very well. How do you rewarm them? Well, you can do it passively. You can do something like a bear hugger. I know that for me, at 5 o'clock in the morning, that no one on this planet should be awake and working at 5 o'clock in the morning. It's just unhealthy. You have no cortisol. You feel sick. Everybody feels sick. To me, the best use for a bear hugger is for you at 5 o'clock in the morning when you're feeling. It's like, oh good. It's like having, I don't know. It's like mom. It's like, oh, it's a great place. For your patients who are cold, it's a wonderful way to warm them up. Cover them with a warm blanket. That's the passive. You can do active though. So say you have that person who's coding, and all hands are on deck. You know it's going to take a while to get that person rewarmed. You're going to want to try active rewarming in those people. So you're going to do things externally, like putting hot water. It's the reverse of what you're doing with heat stuff. You're going to put hot water over big vessels, so the groin, the pits, the neck, etc. Use the bear hugger, and you can consider active core rewarming as well. One great way to do this is if somebody, especially if they're spontaneously breathing, is warm humidified oxygen. When you're cold in a room or you're cold and you're camping, what do? You put your head under the covers. You put your head in the sleeping blanket because you want to breathe warm air. Do that for your patients. It's a great interface, a great surface area to get some warmth in the patient. Consider warming your IV fluids. It's not going to have a huge amount of difference, but it does help some. And if you really, really need to, irrigate the bladder, lots of surface area that's blood supply. Irrigate the stomach, lots of surface area with blood supply with warm water. Okay, that's all you need to do is warm water, and that gets your temperature up more. So you've got that coding patient, you should be doing this jazz to try to get their core temperature up. And the idea that you have to get them warm before you can consider them dead is crazy, right? Honestly, dead people are cold, and they stay cold. I mean, it's like, hello, they just stay cold. I can't get somebody who's dead warm if they're really, truly dead. The key here is if somebody really, it's like, geez, their core temperature is still 28 degrees. We can't get this temperature up. They're still, cardiac arrest. When can we call this thing? Check a potassium. If the potassium is greater than 10, some people say 12, some people say 10, but if it's just really off scale and they're still in arrest and they're still cold, you're done. Okay, they're not going to come back. Okay, you're done. That's really the best sort of gauge for you on when to just call it quits, you're finished. The other sort of little aside to that's true even in children, but in children, please give it a little bit more of an effort. There are some amazing stories. Children tolerate cold remarkably well, and especially if it's a kid who is underwater and is cold. Those children can have been dead for hours and come back with totally normal neurologic function. So have a little bit more aggression when it comes to children. Now, another version of cold things, other than hypothermia, is what can happen to your skin. I want you to think of frostbite as a thermal burn equivalent caused by cold. If you think about it the same way, you will never get anything wrong on frostbite. And if you want to learn a lot about frostbite, read John Krakauer's Into Thin Air. It is a phenomenal book about the Everest climb that went so badly these many years ago. And he gives a really amazing description of what frostbite looks like real deal while you're watching it happen. So frostbite itself is frozen tissue, irreversible damage done to the tissue. There's a thing called frost nip, where you get really, really cold, but you didn't damage it yet. That's reversible. But once you're in a true frostbite, it's like a burn. First degree is superficial. It's erythematous, it doesn't blister, but it's truly you've done some damage to your skin, okay? That one's first degree. Second degree, you've gone down deep enough, just think about this like thermal burn, same deal. You've gone down deep enough to get to the blister level, but not so deep that you've gotten to where the blood vessels are. So I have a blister now that's sort of a superficial one. So the blister is clear. If I have third degree frostbite, my blisters are now hemorrhagic. I have frozen down to blood vessels that have now ruptured. So my blister is now bloody. That's worse. Okay, and my skin is necrotic under there. And fourth degree is the chicken leg you stuck in the freezer 2 weeks ago and forgot about. Okay, that's actually true. Honest to God, frozen down to bone, that's dead tissue. Clear blebs are good, bloody blebs are bad. If you have someone with frostbite, so say you're out with friends and you end up in some horrendous situation and they have frostbite, don't let them rewarm and then refreeze. And you're better off letting it stay frozen until you can get it basically rewarmed and stay rewarmed. Rewarming and refreezing is deadly to tissue. So refreezing is bad, very bad. And if you see somebody who you now can fix it, you're in the ER or you're with friends or whatever, what you want to do is basically get them into really warm water. You want the water about 40 degrees centigrade, and you want that stiff to basically reverse as quickly as possible. You want to rewarm it as quickly as possible. The blisters themselves, clear blisters are recommended at this point in time. This is what the test would want to know. It's recommended to take a clear blister off. But if it's bloody, it's recommended to keep it intact. Okay, if it's intact, leave it intact, not to take that thing off. And the whole point of frostbite is to not do any damage to tissue today, because it demarcates itself. The epilogue to John Krakauer's book talks about what happened to all of the individuals who survived that particular expedition. And he shows pictures of the guy who basically, it's a physician who was with him, who lost both ears and his nose and most of his fingers. But if you'd seen him before those all happened, he looked like everything was going to go. I mean, all of his whole face looked. So what he lost was the tip of his nose, some of his ear, not all of it. It demarcates itself over time. So don't you do it, let the body do it itself. It will sort of show over time what needs to go. Now you can have cold injuries that aren't related to freezing, that aren't truly frostbite, which is the mother of the skin, sort of skin stuff. This is actually, so trench foot. If you want to read about trench foot, you can read books like All Quiet on the Western Front by Le Remarque, which is a book we all had to read in school, but there's some wonderful descriptions of standing in the trenches in freezing temperatures in World War II with your feet really wet in this gloppy, mucky stuff, and people getting basically trench foot, which is a non-freezing injury of your feet, but your feet are cold for prolonged amounts of time, in wet feet in cold. What it does is it damages the nerves. Okay, it badly damages the nerves. When you take those boots and socks off, their feet are mottled looking. They have agonizing pain on reperfusion because the nerves have been completely damaged. It's sort of like what happens to the nerves during a burn. But the nerves are just really, really damaged. And even if they recover, which they tend to, their feet give them trouble for the rest of their lives. They have regulation problems that are neurologic regulation problems, like they have hyperhidrosis, they have sweaty feet, and terrible cold insensitivity. Great descriptions of this in some of the literary novels that are out there. It's kind of fun. Chilblains, I've actually had chilblains myself. I'm a fisher person, I love to go fishing, and I went fishing in a really cold area. And once I'm fishing, I could freeze to death and I wouldn't notice. Because fishing is very zen, and you kind of get off into the zen space. And I was drenched in water. It was cold, I had jeans on, that was totally stupid. And my jeans were kind of wet on my thighs. And I got back to the room, and I had the most incredible itchy bumps on my thighs. I was like, what is this? This is driving me nuts. Basically, it's chilblains. Often it's cold, it's cutaneous only, it looks like prickly heat caused by cold. Okay, it looks just like prickly heat caused by cold. Itchy, itchy, itchy. Rewarming tends to make it a little better. It does go away on its own. If it's really bad, you can use certain drugs for it, but honestly, it usually tends to go away. It's just kind of annoying. All right, let's flip to the other end of the spectrum. Let's go from the cold stuff to the hot stuff. And it's very timely to be talking about this because it's going to be 113 degrees outside today. We are in the heart of hotness. Let's talk about heat-related illness. There are certain people who are predisposed to get heat illness, and this all makes sense. Okay? People who use drugs, people who drink alcohol, people who have underlying heart disease where they can't get their blood supply to the right place to get them to lose the heat they need to lose. People who have had burns where they've lost their sweat glands. You need your sweat glands a lot in heat-related stuff. People who are overweight have a lot of problems with heat illness. All of this stuff makes you more predisposed to heat illness, but I will tell you right now, I can make every single one of you in this room get heat illness today, in this room. So heat illness we'll talk about it later, but I can literally make all of you develop heat illness today in this room. So heat illness is not just only certain populations that get it. Anybody can. The spectrum ranges from heat stress, which is basically you're walking the strip today at 5 o'clock because you want to go see Bellagio's fountains, and you're walking up and down the strip, and you just feel really uncomfortable. You're sweaty, you feel good, it's hot, you're uncomfortable. That's heat stress. It's your body saying, get inside, dork. Go find some air conditioning. It's too bloody hot out here. That's heat stress. Heat exhaustion takes it to one further level. So you've been dragged out, you decided to go do the shopping mall thing up and down the strip, and you're in and out, and you're hot, and you're walking, and you're shopping, and you're carrying your bags, and you feel kind of sick to your stomach, and you feel kind of nauseated, and you're really sweaty, and you feel kind of clammy, and maybe even a little cold even though it's hot outside. What you have there is heat exhaustion. You're pushing the envelope here. What you're doing is you're not hydrating enough, you're not letting yourself cool down, you may not have enough salt in your system, and you're thirsty, you feel nauseated. It's called the summer flu in places like Las Vegas, because people will go out and get themselves into a situation where they're just in the heat too much. Okay, that's a problem. Okay, that's an issue. That's heat exhaustion, and that honestly is a warning sign that you better get hydrated and you better get inside. Because if you continue on that path, you may cross the threshold to true heat stroke. Heat stroke is all bets are off. We are now into a major syndrome. This can kill you. It does kill people every single year. Chicago is in its heat wave. New York is in a humongous heat wave right now. In Paris, they lost 25,000 people to heat stroke several years ago. This is a big issue. It definitely kills people. The sine qua non on this is altered mental status. So you go from, I'm feeling a little queasy and clammy and sweaty and I'm hot, but I need to finish my shopping because there's a sale down at the, whatever, I gotta go. And so instead of going inside, which you push it too far, and now you go from that to altered. Okay, the altered mental status. That is what defines the illness. Heat syndromes come in these sort of ranges. It's sort of a spectrum. So they come in different flavors. The minor syndromes are things like that heat stress or heat cramps. So if you're a runner and you decide to go running today, or more so if you are on a construction site in some place like Las Vegas, and you are got up and down the ladder to put things doing your construction stuff, and now you go home at the end of the day, and you take your shower, and you're sitting watching television, and all of a sudden you get gnarly Charlie horses in your legs. What you're getting is heat cramps. Usually happens on cooling, not during exercise. Usually happens in big muscles that have been exercised during the day in heat. And it's probably a hydration and sodium issue. Probably these people just need a little bit more hydration and sodium during the day to prevent it. Heat edema is what some of you may have had on your honeymoon. So you get married and you decide to take your honeymoon in the Caribbean and you get off the plane and you have, for the ladies, you have your strappy little sandals and your cute little sundress and you're all ready to be the new bride and you're walking around, except day 2, you get up and you have cankles. And you can't get your ring on or off, which is probably good if you can't get it off. For the men, it's good you can't get it off. So you have your ring that's stuck on your fingers because you have heat edema. Basically, you're in a hot environment, you're not used to that. This is something that goes away on its own, doesn't need anything, and that's very, very common. You can get it here, just walking down the street, heat edema. Heat syncope happens during graduation time of year. Grandma, grandpa, mom, and dad, and all the cousins are watching, Charlie graduate from UCLA. It's hot outside, they're standing because there's standing room only, and boom, they go down. That's basically pooling of blood in your ankles, pooling of blood in the periphery, not enough to your brain. It's basically because of the heat, you go down. That's easily fixed, lie them down, get them some fluid, get them cool. Prickly heat is basically the same thing as chilblains, but from the heat. And babies get this. Babies get this a lot. It's just miserable. It's itchy, itchy, itchy. Basically blocks sweat glands, itchy stuff. Moderate heat illness is that heat exhaustion I mentioned. It's like the summer flu. Heat stroke is core temperature really high. That's severe stuff. Heat stroke is bad news. CNS changes are the kicker to that. Now, in school, you learned that heat stroke happens to elderly people in their homes in Chicago without air conditioning in the summer, right? It's the old person who comes in hot, altered, dry skin. That's that person. And that's called classic heat stroke. That is sort of the classic presentation of heat stroke. However, the reason I can make all of you have heat stroke in this room today is if we decided to power down exercise for the next 4 hours. We're going to do aerobics in place, in here, for the next 4 hours. We're not going to stop. We're going to run around this room. You can generate enough heat by exercising to overpower your body's ability to lose it. So the people that tend to get this are basically football players doing training in the summer. We lose kids in high school football stuff every summer, it happens every summer, and the military. You put a 75-pound pack on a military recruit's back and you tramp him through Palm Desert, California in 120-degree weather, you can give them exertional heat stroke. So this is the two groups that tend to get this the most, or that get that, but you can get it even in this room. I will tell you one of my stories about exertional heat stroke in a second. So this is a table that summarizes the two. The thing to know that the difference of the two is that exertional heat stroke patients will have heat stroke but be sweaty. We tend to think of heat stroke as the skin is dry phenomenon. This is actually, no, the skin is sweaty in these folks because they know to hydrate. They're still sweating. They just are generating way too much heat. They just can't get rid of it fast enough. So they're often sweating and they have more likelihood of badness from exertional heat stroke. They go into DIC. They get rhabdo often because those muscles are being used. They get pretty sick. And their mortality rate is about 5%. Classic heat stroke tends to be dry. Okay, their skin tends to be dry. They get ATN, that kind of thing as well. But they tend to die more often because they have underlying issues. So classic heat stroke is more lethal, mainly because of the people that get it. Exertional heat stroke can still kill you, but they tend to survive more. They have more DIC, but they tend to survive more because they're basically pretty healthy. The manifestations when you see them are they're hot. Okay, hot, hot, hot. And we all know oral temperatures are absolutely unreliable. If you see somebody who comes in and they feel warm to you, get a core temperature. The best core temperatures, honestly, are either esophageal or bladder. Okay, rectal is probably not the best. What you're measuring is how warm the stool is. You're not necessarily measuring how warm the person is. So bladder or esophagus are probably the best ways to measure temperature. They're tachycardic, they hyperventilate, they're altered. These people are really, really sick. Really, really sick. Often go into multi-organ system failure because your body can't keep up with it. Okay, they can't keep up with the heat stress. And again, altered mental status is the key. If they give you a question and somebody has a temperature of 39.2, but they are walking, talking normal, they do not have heat stroke. Okay, heat stroke. Oh, another little ditty. Altered mental status and severe hyperthermia, we're talking 106 or higher, in an adult, the differential mnemonic is time. Toxic, infectious, metabolic, environmental. We remember the toxic, we remember the infectious, we sometimes remember the metabolic, which is thyroid usually, and we sometimes totally forget environmental. So the altered mental status little old lady that gets brought in from the double wide trailer park down the street, we see this all the time where I work, bring them in, she comes in altered and febrile. You want to remember that if she's altered and febrile, you're going to want to remember environmental. Ask the paramedics or ask the family members, was that trailer hot? Was it hot in there? Because otherwise you're going to miss heat stroke as the cause of her being so hot. So just filter it in there. Time, toxic, infectious, metabolic, environmental. Super hot, altered, worry about that. Your objectives for these people is to cool them, and your ABCs change to CABC. So while you're doing your resuscitation and your evaluation, et cetera, you are cooling them. So somebody who comes in with a core temperature of 40 degrees or higher, I don't really care how they got there. I need to get them cool. While I'm figuring out how they got there, I'm going to cool them down. There are several ways of doing that. You can do the ice packs like we do now with therapeutic hypothermia, but better yet, evaporative cooling is the best way to go here. Strip them down, spritz them down, or take a sheet, dunk it in water, squeeze it out some, drape it on them, and then get a fan. In fact, there are places in Saudi Arabia, as people do their trek to Mecca, there are hospitals in Saudi Arabia that have cooling rooms. What they basically do is they have these it looks sort of like a scene from Coma, the movie Coma. They have these hammocks strung up across the room, and what they do is they put people in these hammocks. They're made of a mesh. They spray them with water. It's a mister that just goes spraying all the time. They get sprayed with water. And then there are fans that blow across the room. Because evaporative cooling is a very, very powerful way of cooling someone down. 0.1 to 0.2 degrees centigrade per minute. You get really good cooling with evaporative cooling. I'll tell you the challenge to you in your real world is I challenge you to find a fan that you can use in your ER. Because the Joint Commission has decided that fans blow cooties around and that we can't have fans around, because they blow cooties around. And honestly, they probably do, except that every once in a while, it's very helpful to have one of these. We had a heat stroke patient at Harbor several years ago now, and we really needed a fan. We really needed a fan. So we couldn't find one. There wasn't one anywhere. So I gave the medical students some money and sent them across the street to the drugstore. I said, go buy a fan. Just go buy a fan, go get one and bring it back. This person really needs a fan. Well, unfortunately, we were having a heat wave, and the only fans that were left there were these little tiny, like put it on your little push the button, and that wasn't obviously, that wasn't going to work at all. So what we ended up doing was getting when they do strip the floors and re-wax the floors, and they bring those things that sound like a 747, we got one of those. And we actually put it up on the counter. We learned a couple things about that, though. Anything that can blow away, get out of the way, because literally anything that wasn't tacked down got blasted across the room. But it worked really well for the patient. It cooled the patient really fast. We have subsequently learned that we have a box fan in one of our offices over in the office building, so that if we really need it, we just go over to the office, we bring it back over and use it. And Joint Commission be damned, we at least have the fan. So evaporative cooling is the way to go here. Remember the ice and stuff as well, but evaporative cooling is the way to go. Immersion cooling, take that person and stick them in slush, ice slush, which is what they do at a lot of the big concert venues, these outdoor hot concert venues. That actually is not terribly feasible and honestly probably not the best way to go. The theory here, and it's a theory, but it has some credence, is that you clamp down peripherally and you shunt the hot blood to the center. And there's some evidence that there may actually be some problems with that. The key for you is evaporative cooling, put ice over the big vessels. That's the big thing to do. So water spray, evaporative, all this stuff works. Immersion, generally not recommended. Let me tell you my story about my exertional heat stroke patient to drive a point home about this. One of the other things about heat stroke is if it is truly heat stroke, as they cool, they should have their mental status improve. If as they cool, they don't have their mental status improve, it's something else. In that time differential, it's now toxic, infectious, or metabolic. Because if it's truly heat stroke, as their temperature gets down to more sort of the 39, 38.5 degree area, they should become normal. Okay, they should actually talk to you and tell you what happened, etc. So let me tell you my exertional heat stroke story. In San Francisco, when I was a resident up there, my first residency, there was a marathon run that happened in San Francisco, and there was a young woman who wanted to run it, very much a marathon runner, wiry thin, really ran miles every day, had all the whole brain endorphin thing going on. She was wonderful. She was engaged to had a boyfriend who was a Taekwondo black belt, 6'4", all muscle, Taekwondo black belt. So they were boyfriend, girlfriend, and he decided he was going to run the marathon with her. If she can do it, I can do it, damn it, I can do it too. And he didn't train. So this man with the Taekwondo kind of brain powered himself through a 26.2 run. And he did it. He finished it. Without training ever, he finished it. Crossed the finish line and went ballistic. Started assaulting people, was violent, and this is a Taekwondo black belt. Everyone at the finish line is like, what is going on? He was crazy, crazy, crazy. Paramedics got called. It took 6 of them to hold him down in the back of the ambulance. We get this call, Taekwondo black belt going wacky. This guy's coming in, rolled in, just touching him. He was drenched in sweat. He was slippery like crazy and so bloody hot. He was so hot. Tied him down, held him down, just drawing his blood. It steamed up the tubes, inside the tubes. I mean, he was unbelievably hot. We cooled him down, and as he cooled down, he actually became a very nice, lovely guy. He actually became totally normal, was, told us what had happened. His girlfriend was really worried. He said, can I see my girlfriend? She got brought into the room. It was all this, oh, honey, oh, honey. And he, at that moment, proposed. So all the women in the room went, ah. And all the men went, he's still altered. It was actually kind of a great story. The guy did poorly, actually. He had DIC, went into renal failure, eventually did fine, and they did eventually get married. But it was a very vivid demonstration to me of what heat stroke and what you can do to yourself, giving yourself heat stroke, and what happens to you as you get better. All right, let's talk about what other heat things can happen to you. Let's talk about burns. So they love burns. Okay, burns will be somewhere on your test. They love burns. The odds are high that they will put a burn question on there. So certain things you need to just stick in your brain and know. Burn degrees depend on how far down the tissue gets burned. So sunburn is your first degree. Okay, it doesn't blister. That's your minor sunburn deal. That just is uncomfortable, a little bit of aspirin, a little bit of topicals, you're done. Second degree, you actually get down to where the dermis is damaged. And you get blisters with second degree burns, okay? So that's basically sensation is intact, but you get a blister. And there's sort of partial thickness burns, basically. Third degree, it's full thickness. And you now get down to the structures of the skin, the blood vessels and the nerves. Okay, now you've gotten down so far, you have damaged those. And that is an anesthetic area. The nerves are now dead. The nerves have been burned. So third degree burns are anesthetic. If they show you a picture of a burn, and they say the area in question is insensate, that tells you that is a third degree burn. Okay, the nerves have been damaged. Fourth degree burns are unsurvivable if they're big enough. Okay, I've only seen one person alive with fourth degree burns. She didn't live very long at all, but fourth degree burns are that chicken leg, instead of being left in the freezer, you stick it on the barbecue and you forget that it's there. And you go back and it's basically charred all the way down to bone. That's a fourth degree burn. The person I saw was somebody trapped in a car where her legs were in the burn and the rest of her was not. And she got fourth degree burns basically from thigh down to both legs. It was an unbelievable thing to see in a living person. This is usually a coroner's kind of deal. That's what they see. That's fourth degree burns. We see first, second, and third degree burns. This is one of the slides you're going to want to asterisk. This one and the two that follow. They want you to know body surface area. Okay, they're going to want you to be able to calculate that. They're also going to want you to know the fluid resuscitation for someone who has a burn. The one that tends to be defaulted to most frequently is the Parkland formula. And it's here. It's 4 cc's times the weight in kilograms times the body surface area, second and third degree burns. Lactated ringers is the fluid. That's not as important, but it is. We'll talk about why lactated ringers is better. You calculate that number, and you give half in the first 8 hours, the second half in the next 16. So what they tend to do is give you a question that says an 18-year-old man comes in with burns on both arms and the front of his chest. How much fluid do you want to give him in the first 8 hours? So they're going to want you to know what's the body surface area of each arm and the front of his chest, and they're going to want you to know that formula. So however you want to remember it, memorize it the day before, whatever, this is something they like to ask. And that's how they like to ask it. It's a 2-part question for these. So for him, the anterior part of the chest would be 18%. Each arm is 9%. So that's 36% body surface area burn. You're going to plug it into the times 4, okay, times his weight in kilos, divide that in half, give that over the first 8 hours. So that's what you're going to need to know. Children have a different sort of body surface area, and babies, small kids, toddlers, 2 and under, definitely have different. They're basically a head with a body attached. Anyone who's given birth knows it's a head with a body attached. The head, once you get that thing out, the body's like, no big deal, comes right on out. But if they burn, they have burns, their surface area is different. Their head, 20% of their body surface area is their head. So just know that there's different proportions. Again, asterisk these. This is something you're going to want to remember right before the exam. I don't think they'll ask you a burn center admission kind of question, but because they vary a little bit place to place. But know that certain things are definitely burn center stuff. Circumferential burns tend to go to burn centers. High proportion second and third degree burns, body surface area burns go. Facial burns go. Genital burns go. Crease burns go. So big, second or third degree burns over creased surfaces. Hands are a big one that need to go to burn centers. I don't think they'll ask this, but just keep this kind of in the back of your mind and use your logic if they ask you a question like that. It's just logical, the kind of things that do better in a burn center. So they may give you pictures like this. This poor little guy has both second and third degree burns. So the white ones there are third degree, they're insensate. Those ones that show all the little red spots in them, those are second degree. You still have some of these skin appendages that are still available in there to have some healing. Third degree burns won't heal without surgery. Okay, they need to be basically grafted. These are third degree burns. Okay, there's a little bit of second degree down in those pockets that are red, but everything else on this is third degree. Okay, this is something that will not be fixed without grafting. This is burn center material. The complications we worry about don't tend to happen for us in the ER. So the infectious stuff that happens down the line, that's down the line. That's something that we just don't really have to deal with very often, but somebody with a lot of body surface area burns can get ARDS. More commonly, though, what they're going to want you to know, what we need to know in real life, is that people who have burns, especially in enclosed spaces, may also have a toxic exposure. Either carbon monoxide, because of the burn sort of related carbon monoxide, but also cyanide. So cyanide is in certain things, like certain types of seating, certain types of foams and things have cyanide in them. It turns out airplane seats, old ones, if you burn those, release cyanide gas. So there are other things that can occur that can cause lung problems or mental status issues or metabolic abnormalities that are related to toxic things, not just the burn. So know that that's a complication that we may see in the ER. Most of the rest of these kind of come a little bit down the pike. One of the other things to know for real life and for a test is escherotomy and when to do it. How many of you have done an escherotomy in your career? I've done several. Have you have done a chest escherotomy? See, hands high, I'm kind of curious, because this is gnarly, but it's amazing. So an escherotomy is based on the principle that if I have a third degree burn that is circumferential, where it basically is creating a sleeve or a corset or a noose around someone's neck, it is now, it's like leather, okay? The skin when it's third degree burned is like leather. It doesn't have any give at all. I need to fix that, and the only way to fix that is to cut into it. The way they'll present a question to you is they'll give you a patient who has, for instance, as an example, circumferential chest burns. They'll say a patient comes to the emergency department with circumferential third degree chest burns. And what they'll give you is a blood gas. And the blood gas will have hypercarbia and a respiratory acidosis. What they're going to want you to recognize is that CO2 retention is happening because that chest is restricted. Somebody has restricted breathing, and they're going to give you options. What would you like to do? I would like to intubate this patient. I would like to give this patient, I don't know, whatever, drugs, etc. But they're going to give you an option of perform an escherotomy. They're going to want you to recognize that CO2 retention is because that person has a stiff chest wall from a 3rd-degree circumferential burn, and the only way to fix it is to cut it. Now the thing, if you've done one, you know this, but cutting into somebody who has a 3rd-degree burn, bad enough to need an escherotomy, is a relatively benign procedure. It's insensate, right? They can't feel anything anyway. Okay, so it doesn't hurt them, which is kind of nice. And it's literally like when you have a hot dog you've cooked that's just perfectly cooked and you tap it with a knife and it pops open, that's what happens when you do an escherotomy in somebody who really needs it. So if they have distal neurovascular compromise and a circumferential arm burn that is 3rd degree, you're going to cut it. The thing is, cut away from important structures. So do your cuts, usually linear, do them away from important. So you're not going to obviously do an escherotomy right over the antecubital fossa. You're going to go over spaces that aren't going to cause any significant damage. And the way to do it on the chest is there's various sort of approaches. Most people recommend the H. Basically going mid-clavicular line, avoid the nipples, go right down the two lines of the H here, and then across the middle, and it allows the thing to open. In the neck, just basically go away from the significant structures, but get it so that you have usually two cuts when it's in the neck. So that's an escherotomy here, and you're going to see the pop will happen. It doesn't hurt. Subcu tissue will show up in that area in the wound, and now they have some function. So escherotomy is something they may test you on. They want you to recognize that it's compromised distal to or caused by that circumferential burn that's the issue. All right, other things that can cause kind of burns are electricity. Let's talk about electricity. I hate electricity. I hate it. I hate it. I hate it. Every time my husband works on the electricity in the house, it freaks me out. I got shocked as a little kid, in the wall. I hate it. It's just awful. It's awful. Electricity causes damage by causing heat primarily. It can also do it by disrupting electrical circuits. If you keep that in mind and understand also that electricity likes to go down things fast, it doesn't like to dally. It doesn't like things that get in its way, that cause increased resistance to its pathway. So it makes some sense, the kinds of injuries that occur from electricity. So traumatic injuries are common because one of the things it can do is basically either throw you or you jump back. So trauma is common in these. Electrocution is it kills you. And the people who are at risk for this are the people we would expect. Utility workers, they're usually pretty good at this, but I'll tell you, they deal with the big deal stuff. Copper scavengers. During the recession, there was a big sort of group of people that were getting electrocuted who were scavenging copper from housing projects that got abandoned during the recession. And some of those copper is very valuable on the market, and they were going to houses and basically stripping all of the electrical wiring out of people's houses, but some of them were live. So I saw one guy who died trying to steal electricity, tried to clip it, and got electrocuted big time, trying to scavenge copper. So that's another group. Toddlers, we know. Toddlers explore the world orally. Everything goes here first. Everything, including the power cord or something that's near a socket. So kids are at risk. And then adolescents, because they're stupid. They just do stupid stuff. Adolescents do dumb stuff. So adolescents are also at risk. They'll climb the power pole. They'll do dumb stuff. The clinical effects, though, are dependent on AC or DC current, how much current, and where did it go. So you don't have to know all these electrical resistance and amperes. You don't have to know that. What you need to know is AC current, alternating current, is worse than DC, 3 times worse. What it's doing is the current is basically alternating, which causes tetany, causes muscle spasm. Direct current zaps you once, it can zap you big, tends to throw you. It doesn't cause tetany. So if I happen to touch something that's direct current, I get thrown or fried on the spot. If I touch something with an alternating current, because it's alternating, my muscles start to cramp up. And there's a thing called a let go current where I cannot let go even if I want to. It's causing tetany. That's why alternating current is so much worse. Plus it's what we have in our homes. So the alternating currents is something that we're close to. Also, the tissues it goes through, depending on the resistance of those tissues, certain kinds of damage will be done. So for instance, it loves your nerves. It loves your nerves. Electricity goes running along your nerves, no problem. dashes right along those things. Hates your bones. Your bones don't conduct it very well. So it gets stuck there, and when it gets stuck there, it generates heat. So on the range of tissue resistance, nerve is the best, it's the fastest. Blood's not so bad, it can travel through your bloodstream just fine. Muscle's a little worse. Skin, it's not great, but it's all right. Tendon, fat, and bone, hates it. Hates it, gets stuck there. So the tissue damage often is to tendon, fat, and bone. Those are the things. So if you've seen somebody who gets electrocuted, this guy with the copper, he basically had congealed his arms. He'd gotten so much electricity through his arms that they was like knocking on a piece of wood. Everything was just congealed. It was all rock hard because it had gotten cooked. It had gotten cooked from the inside from electricity. So AC wounds, you tend to have an entrance wound that's bigger. DC wounds, it goes through you quickly and blasts out the other side. That's what the DC does. Injuries vary depending on what's happened. So, depending on the tissue current and depending on the tissues involved, you'll see various things. And again, I mentioned the let go current. There are numbers in here you don't need to remember. Just know that AC current, because it causes that tetany, causes your muscle spasms to cramp, it's the AC that can keep you hanging on. Also depends if you're wet. They're great sort of dumb person, I think they're the Jackass YouTube videos, the dumb ones, where people like there's a ladder that has the warning on the ladder, please do not place, metal ladder, do not place in water and fix electrical equipment. Duh, really? Really? It's on because people do dumb stuff. All right, let's talk about low voltage. Remember, voltage makes a difference, so how much power is in this thing. Low voltage injuries are more common because there's more low voltage stuff out there. It causes half of the injuries and deaths that we see. The burns themselves are minor. This is the stuff that you get in your house, okay? You can die by dropping your hairdryer into your bathtub. You can die from that. It's a low voltage deal, but it can electrocute you. Basically, when it does that, it goes to your heart and screws up your heart electricity, causes a VFib arrest. That's how it tends to kill you. The low voltage stuff tends to kill you, not by giving you big burns or anything. The electrical system in your body gets altered by this low voltage stuff in the system, and VFib is what it likes to do. It likes to cause VFib. High voltage is different. High voltage injuries basically blast you. They basically, and these are the power lines. Our power lines are super high voltage. The third rail, super high voltage. These things are extraordinarily high. And these cause massive skin burns. So it usually causes a burn where it hits, but a big burn where it goes out. And because they're so powerful, you often get thrown, or if you don't get thrown, there's so much sort of jolt that goes through your body. Dislocations are common. This is the posterior shoulder dislocation that you kind of hear about. Fractures are common. Trauma from being thrown are common. So these pictures basically look like a crush injury. They have lots of trauma and they have lots of sort of muscle damage that occurs with this. What you want to do if you have somebody who has an electrical injury is you're going to send labs, and you're going to add a lab to that you don't normally send, which is a CK. Okay, you're going to add a CK because you're worried about those muscles as well. You check the urine, beyond all the other stuff you usually check. Add a CK and think about it. Consider imaging if you think it's appropriate, but get an EKG. What you're really looking for on the EKG is dysrhythmias. There may be an injury pattern that you see. It's diffuse if it is, but you're looking basically for dysrhythmias on these. If it's a household exposure, they have normal EKG, everything else is good, everything else is fine. I felt a zap when I was working on the electricity in the house. My hand was tingly for a while. Now I'm fine. No, I wasn't dizzy. No, I didn't have chest pain. None of that. You get an EKG, it's fine. They get to go home. Okay. Otherwise, if it's a high voltage injury, they need to stay. We'll watch them. This is what they look like. This is high voltage. Okay, this is somebody who touched something that was a high voltage injury, and that is an instant third degree thermal type burn, and it can cause all kinds of damage underneath the tissue. That's another thing about electrical injuries. What you see on the outside is way worse on the inside than what you see. This is the thing they like to test on the exam. Unfortunately, we don't see as much anymore because people are pretty aware of child-proofing houses. But this is the commissure burn in kids. This is that kid exploring the world orally, gnawing on the sort of wall socket cord that's coming out of it and getting a burn. The key to this burn is that the burn in and of itself, once you've taken care of the initial event, is usually not that big of a deal. It eventually can cause some scarring. But the worry is at about anywhere between 5 and 10 days. Because as that eschar retracts, at the corner, you can feel your own pulse, by the way, right about here, there's a labial artery. That's a real artery. And when that eschar comes off, these kids can bleed, and they can bleed a lot. If you go to the textbooks, which is what this test is going to be based on, if you go to the textbooks and kind of try to find out what they recommend to do about these, there's kind of a broad range. One textbook recommends to admit them all. Okay, I don't think that's feasible. That's kind of crazy, to be honest. But the reality is you must warn families about this, that it may occur, and at about 5 days, they probably should get checked to see how this is going, just to make sure that there's not any risk of bleeding. So just know that that's a consideration. And admission may be something at that point in time. Oop. As far as the electricity that is sort of at the extreme of electricity is, God or Allah or the power that be, the electricity that comes from the sky, which is basically lightning injuries. The bottom right-hand picture in this is taken in Hermosa Beach last summer, which is where I live. Okay, I live down in the South Bay area of Southern California, and there was a guy who got electrocuted from lightning in the summer in Southern California while swimming in the ocean. Go figure. We've had 3 major thunderstorms in Southern California last week and a half. Major, huge, lightning, thunder, the whole shebang. So lightning is a big deal, and it can even happen in places that hardly ever get this. Lightning is a big. I also read a story in that wonderful medical journal USA Today yesterday about a guy who was hit by lightning as a kid, struck by lightning, survived as a kid, and then won the lottery day before yesterday. So maybe you want to get hit by lightning. The odds of that were something like 1 in 3.2 billion to both get struck by lightning and survive and win the lottery for the same person. That guy is like golden. He's amazing. So let's talk about lightning. Lightning is DC. Okay, it's not AC, it's DC, and it's DC with a vengeance. It's 50,000 volts a shot. It is huge DC electricity, enormous. If you get hit, you're never really quite the same. It turns out, I think Rick has a cousin who was hit by lightning, who has just been a little off his whole life. It scrambles your brain a bit to get hit by lightning. You can get lightning struck various ways. You can get struck directly. So God says, today's the day. Or you can be near someone who gets struck. Or you can have on something that basically attracts some of the electricity, but you don't get struck. Or you're in water and it hits over there. Or you're a side strike where you get hit by the blast, but not the electricity itself. There's a lot of things that can happen with lightning strikes. But if you get hit, it's a massive, brief shock. And it causes just basically massive DC sort of a shock through your body. Your TMs are often ruptured because when lightning hits, it also causes a pressure change in the air, so your TMs get blasted out. And if you get struck by lightning, you are temporarily paralyzed. It's sort of like succinylcholine on steroids. You depolarize everything all of a sudden. So you have temporary paralysis, not just of your muscles, but also of your diaphragm and of your pupils. So if someone's been struck by lightning and they're in a cardiac arrest, you can't use their pupils for more than 24 hours actually to determine if they're actually salvageable people. And if they come in cardiac arrest, what happens is you get struck by lightning. The first thing that happens is your heart stops. The rhythm isn't V-fib. It's basically whoa, and it just stops. Okay, it just stops. What is interesting about it though is if you get hit with that much electricity, eventually your heart dusts itself off, gets itself up, and starts back up again. The problem is the depolarization of all your muscles included your diaphragm, and that doesn't come back quite so quickly. And in fact, what tends to happen is your heart starts back up again, but your diaphragm doesn't, and you end up with an apneic arrest eventually. It's like, it's God with a bad sense of humor. I mean, this is like mean business. And in fact, there's a story one of the last year's course participants told me where there was a chaplain at the scene of someone who had had this happen. And basically the paramedics were coming and he basically blessed the patient and did the last rites and the whole thing. And they basically started to bag the patient. And as he blessed the patient, they bagged the patient woke up because his heart had started back up because that's what happens. And everyone felt like, wow, dude, you can be the chaplain when I die any old time if that's what it takes. God brought the guy back from death. That's the sort of the path of death though, when you have somebody who gets shocked by lightning directly. The key then is CPR is fine, but you really want to support the ventilation in these folks. We focus so much now on CPR, forget the ventilation. This is one case, like children, where ventilation becomes a big deal. Kids in cardiac arrest, ventilation is key. Adults who've been hit by lightning in cardiac arrest, ventilation is key. That heart tends to come back. So what you also may see are these things. If you have little bits of sweat, all little bits of sweat, basically get these punctate lesions because you got depolarized top to bottom. This is a lightning injury. This is probably actually an entrance wound. The exit wounds tend to be a little bit more blasty than this, but this could be an exit wound. This is a lightning injury. So that's the lightning bit.
How about other ways you can get exposed to stuff? So now we're going to start to get into all the weird little hodgepodgey things that are out there that might fall into the environmental sort of question session. Radiation exposure. This was a big hot topic when 9/11 happened. And it now is background noise for everything we need to think about as far as Homeland Security and things that may come into the emergency department and people that want to do bad things. So radiation exposure is a real deal. The things really for you to know about radiation exposure are that if it is a contact radiation exposure, you'll see a burn. Okay. And actually, Chris Tomaszewski, who's an emergency physician, toxicologist, tells a great story of a guy who came into their ER who had a weird hand burn, very odd hand burn, just a weird hand burn. And about 24 hours later came back again, nauseated and vomiting. Turns out the guy stole irradiated cobalt. He basically had stolen cobalt and was holding onto it in his hand and gave himself radiation sickness. Got the burn from it, absorbed enough of the radiation to get the side effects of that, which is radiation hits fast turning over tissue first. So it hits your gut and it hits your bone marrow. Okay, those are the two areas of your body that it hurts the most quickly if you get radiation exposure. So basically, if somebody comes in with lots of nausea, vomiting, diarrhea, gut symptoms early on, or their skin is giving them trouble, either a local burn or if it's a total body exposure, they start to peel, that is usually a lethal dose of irradiation if they get that early. This is the Hiroshima picture, that horrendous picture of the girl whose skin is falling off as she's running away from Hiroshima. That's a lethal exposure. Okay, that's enough amount of exposure that rapidly turning over tissues are significantly damaged. The earlier the symptoms after exposure, the more likely a bad exposure has occurred as well. All this remembering how much exposure causes it, don't bother. That's not even something they'd ever go to. What they want you to do is recognize the clinical stuff. So nausea, vomiting, diarrhea, skin symptoms, early symptoms. So recognizing those are the things that occur. And again, it's that high turnover tissue, and there's certain cell counts that I don't think they'll hit you with, but there's certain cell counts that might be helpful to say, prognosis is really terrible in this one, maybe salvageable in that one. Chemical weapons are a different ballgame. We need to know about chemical weapons, okay? It turns out even our own CDC wasn't terribly careful with things like anthrax and was sending around anthrax without it being appropriately contained. So we need to be aware of this stuff, and I will tell you flat out, we're the canaries in the mine when it comes to chemical weapons and biological weapons. We'll be the first place that it gets recognized because they'll come to us first. So you need to both to protect yourself and to figure out there's been an exposure, you need to know about this. This stuff, by the way, has been a problem in places like Las Vegas. So they arrested a guy here several years ago in a hotel room here in Las Vegas who was putting together bags of ricin to basically take into the casinos. Maybe that would have been a good thing, I don't know. But the reality is, this is everywhere. The anthrax thing was in DC, basically was Anthrax Gate back in DC. The key to these weapons is to know the way they work. What they want is something that's cheap, something that is easy to get out there, to disseminate, to get into a group of people. If it's biologic, they don't want it to kill everyone right away. They want you to go home with it and give it to your loved ones before it kills you. So what they want is something that's easily, if it's biologic, transmissible, easily dispersible into the environment, and easily passable person to person if it's an infection. So that's the kind of thing they're looking for. So it makes sense the kinds of things that is in the list of the terrorists, sort of go-to bag for bad things. Anthrax is one of them. If you go to New York, I highly recommend going to the 9/11 museum. Not just the 9/11 outdoor thing, which is awesome. They opened the museum just this last year. And in the museum, there's all kinds of really interesting things, but separate from it as well is a quilt. And there's a quilt that goes the entire length of a wall that it basically has the pictures of everyone who died in the towers when they went down, including little pictures of angels that represent the pregnant women, the babies and the pregnant women. They have a whole separate section, that is for the anthrax victims that occurred about the same time. These are the names of the anthrax victims, and this is what the anthrax that got mailed to Senator Daschle. This is basically what happened. It's a biological weapon that was sent out and worked. It didn't work as well as it had hoped, but it worked. Anthrax it's an infectious disease. We know this. It's wool sorter's disease. That's a cutaneous version of this. It's where the anthrax spores get into your skin. It causes local stuff. That's the cutaneous version. It's the inhalational version that the bad guys want. Because it's a spore, and it's a spore that you can get. It looks like a powder. It's a spore, and you can inhale it, and it causes bad stuff. Fever, chills, drenching sweats, fatigue, not a lot of cough, but in lots of nausea, vomiting, chest problems. You get really, really sick, and you die in about 24 hours. Okay, which is, to be honest, it's a dumb biologic if you're a terrorist. It's not that easy for one person to transmit to the next, and you die fast. So it's not a good terrorism weapon if you want to kill a lot of people, but it's not a bad one if you want to get somebody directly to knock them off. So for us, a lot of us got this x-ray actually mailed to us about the time of the sort of Dashelgate that occurred, because this is the x-ray that shows the lymphadenopathy that you get with somebody who has a pulmonary anthrax, inhalational anthrax. We all got mailed this. We all got a picture of this in the mail from the CDC that when this was sort of a threat. So this is what the x-ray will look like, inhalational anthrax. Cutaneous is not as much of a problem, so I'm not going to spend a lot of time on this. This is sort of more of an infectious disease than otherwise. This is what this would look like. Plague is a little different. So plague turns out to be another biologic weapon of terror. It's not just something that you can get exposed to if you go camping in Yosemite, where they found plague in the mice in Yosemite Village, up in Yosemite Valley. This turns out it's a flea-bitten thing. So plague is something that's a flea-borne disease that you get that causes there's bubonic plague and pneumonic plague and septicemic plague, 3 versions. The pneumonic plague is what the bad guys would like, because you can cough this on somebody else. Now, if you recognize it, it's infinitely treatable, but it's a pretty gnarly pneumonia to get. It's pretty nasty. In general, this is not a great biologic. It's in this in this section of slides just to know, because it is one that's considered a biologic weapon. It's not something that we see that often this way. You might see it, though, in a camper that gets exposed to it out in the real world. This is a picture from actually World War I from bubonic plague. This is the buboes. This is not the same as pneumonic plague. Pneumonic plague causes nasty pneumonias. This is basically the people that come in looking really, really sick. They tend to get sick really fast. Now, smallpox. Smallpox is bad news. Most of us have been vaccinated against smallpox, but smallpox, if it were used as a biologic, is nasty business. We can vaccinate against smallpox, that's great. So it's not a great one to use right now because most people have been vaccinated, but if we weren't, smallpox wiped out 1/3 of the population when people weren't vaccinated. Back in the day where it just ran epidemic through populations, Queen Victoria had smallpox. I mean, if you survived it, it was scarring. If you didn't, it was horrendous. It looks like this. It looks like chickenpox, except they're not fluid-filled, they're firm, and they all come at once, not in crops, subsequently, crop after crop like this chickenpox does. This comes all at once. And if you survive this, those all scar. It's nasty business, as a nasty business. Fortunately, not a good biologic. We've all been vaccinated. Aerosolized toxins, on the other hand, badness. Botulism toxin is easy to aerosolize. And you've seen botulism in your practice, or at least should be thinking about it. If you see somebody with diplopia, especially if you see somebody with diplopia who's an IV drug user or a shooter, that's somebody you have to worry about botulism toxin. Okay, they may have botulism. It tends to start with cranial nerve bindings. It inhibits your sort of acetylcholine at the nerve cells, but unlike the nerve agents itself, it doesn't cause systemic stuff. It tends to just cause neurologic stuff. So these don't cause all the other jazz. They just cause paralysis. So the botulism toxin, which is pretty easy to disseminate, paralyzes people. Okay, that's what this would do. Ricin is different. You can make ricin. If you Google recipe for ricin, when I give this lecture, I go online and kind of look up stuff. I'm sure someday I'm going to get a knock on my door in my hotel room from Homeland Security, who's been monitoring my searching on the internet, because I search all this jazz on the internet before this lecture about how to make ricin and how to do biologics and how to blow up your tennis shoes and with I'm sure I'm going to get arrested someday. Ricin, you can get the recipe today on how to make this. It's from castor beans, and it's a toxin that you make from castor beans. It's amazing. It causes lung problems, causes hemorrhagic edema. Okay, supportive treatment, but boy, these people die. They drown. Okay, ricin basically causes drowning. Big deal. Chemical weapons, so those are all biologics. Some are toxin biologics, some are actual infectious biologic. These are true chemicals. So these are true chemical weapons that these occur. The vesicants are what were used in World War I. Mustard gas. If you read some of those novels I mentioned earlier, if you read about World War I, mustard gas is heavy. So if you blast out a shell that has mustard gas in it and it gets diffused, it sits down on the ground, and if you happen to be in a foxhole, so you're even lower, it sinks down to where you are, and it is a desiccant. And what it does is blisters any mucous membrane surface. So it causes skin blistering, eye blistering, mouth blistering. A lot of men went blind in World War I from being exposed to mustard gas. It basically just peeled off their eyeballs. It enters the bloodstream eventually through respirations and through the skin, and it causes just huge necrotic blisters, all mucous membranes, including your gut. Okay, so that's what this does. Phosgene causes pulmonary edema, leukocytes another one. These tend to be things like silofiller's disease. This is things you get in the silos. But mustard is the biggest chemical agent here that you might want to be aware of. The nerve agents, I think, are, of all this stuff so far, I think the one that exam-wise might be worth focusing on are the nerve agents, because they like these for the exam. There's a lot they can ask that are meaty question-wise about this. And this, combined with the tox talk that you're going to hear from Billy later today, will give you everything you really want to know about the nerve agents. The nerve agents in and of themselves, basically think of them as succinylcholine, okay, because they do to the muscles what succinylcholine does. So they basically give you too much acetylcholine in your system. And they cause sludge syndrome, the killer bees, paralysis, and death. So what they do is you get basically too much acetylcholine. You block acetylcholinesterase. So you block acetylcholinesterase, and you increase the acetylcholine in your system. It's sort of like giving somebody succinylcholine. At the muscle level, they get paralyzed. Okay, so that's where it's like succinylcholine. Too much acetylcholine, paralyzed at the muscle level. But too much acetylcholine everywhere else in your body is not a good thing. You salivate, you lacrimate, you urinate, you defecate, you vomit. Every orifice produces fluid. And if you have too much acetylcholine at your heart, you get bradycardia. And at your lungs, you get bronchorrhea and bronchospasm. Those are the killer bees: bradycardia, bronchorrhea, bronchospasm. The nerve agents cause all of those things because it's too much acetylcholine in your system from blocking acetylcholinesterase. The treatment, so if they ever give you somebody who has all of those symptoms and they give you treatment, the first thing to do, other than make sure they're on oxygen, is to give them atropine. What kills them is basically drowning. So you reverse the lung problems by giving them atropine. You actually increase their heart rate as well, but you're going to try to dry them out with atropine, and you give them as much as it takes. And then you give them 2-PAM, which regenerates acetylcholinesterase. So you can now metabolize your acetylcholine. So there's a thing called the military Mark I injector that has it all in one injector. That's what the military uses for you. Go ahead and get that atropine on board, do supportive care, get somebody to figure out the 2-PAM down the line, but that's what you need to do for nerve agents. Let's get into bites. Dude, I just hit a wall. You see somebody with that injury, you know they didn't just hit a wall. You're going to assume that this is a fight bite. Bite injuries, I know you heard a little bit about this from Billy, but bite injuries overall, dog bites, cat bites, and human bites, we flat out know the human mouth is worse, so a human bite is worse. You have any bug called Eikenella corrodens, you know has to be bad, and that's what's sitting in your mouth right now. So, dog bites actually have the lowest infection risk. Dogs tend to bite and then tear at you and do tissue damage, but because it's all kind of shredded apart, the infection rate's not as high as cat bites. Cat bites puncture you so that you're more likely to get an infection from a cat bite because it's a puncture wound, not because they're worse animals or cats are evil. It's just because they have those, I hear that all the time. Oh, cat, you cats. They have that canine that gets down and pokes you in there. Human bites, on the other hand, all those bad wounds, it's the highest infection risk flat out, and it's fast and it's aggressive. This is, I punched somebody in the mouth last night. The next day at 3 in the afternoon, man, dude, what happened? I got this big swollen hand. It's quick. Fortunately, some ER doc or ER practitioner died and went to heaven and said, God, I need 1 antibiotic for every bite. Can you just give me 1? And it's Augmentin. Dogmentin, Catmentin, Humanmentin, basically Augmentin takes care of bites. So Augmentin, beautiful, beautiful drug for bites. Cat scratch fever is kind of a weird thing. I actually had cat scratch fever. Cat scratch fever comes in, it's actually not cat scratch fever, it should be called cat scratch disease. You're not really febrile, and you don't have to be scratched. All you need to do is be around a cat that has Bartonella, that's the organism that has this, and get Bartonella in your system somehow, a break in your own skin, wherever that happens to be, the cat can lick you. They don't have to scratch you, they don't have to bite you, they can lick you and get Bartonella into your system. And wherever the inoculum occurs, you get a regional lymphadenopathy. So often it's in the armpits, because people will pet a cat. They'll pet the cat, they'll get the Bartonella in their system there, and you get a regional adenopathy. So this little girl probably was petting a cat and got Bartonella through either a scratch or petting a cat. And this basically tends to go away on its own. Antibiotics usually aren't indicated. The scarier thing is just to make sure it's not something serious, like lymphoma or cancer, but it tends not to be. So just know, in general, this is a relatively benign disease, and your job is to rule out whether it's a bad thing. I had a young girl I took care of years ago who had this, who was told that she had cancer by her pediatrician. She had a big lymph node here in the back, big lymph node. And mom was freaked out, and I don't know why she came to an ER for a second opinion, but she did. She came to the ER and she said, "Can you just check my daughter and see?" And so I'm examining her, and there's no nodes anywhere else, and she didn't have a liver, she didn't have a spleen, she's 6, she's really cute. She kept talking about Snowy. Snowy, Snowy, Snowy. And I said, "What's Snowy?" "Oh, my kitty." I said, "Oh, really? Oh, I have a new kitty. She's white, she's fluffy." I said, "Really?" I said, "Where does Snowy sleep?" "Oh, she sleeps with me. She sleeps on my head." So it turns out Snowy had scratched this little girl's head, and the regional lymph nodes had basically collected the Bartonella, and she had this big gnarly lymph node from cat scratch disease. So she didn't have lymphoma. She actually was fine. I still get thank you notes from that mom. This kid, she's now in college. She's like out in the real world. This little girl's all grown up, but it's cat scratch disease. Okay, it's not fever, it's cat scratch disease. All right, rabies. You're gonna hear a little bit, I think, about rabies in the infectious disease talk as well. Just know that rabies, the vectors for rabies, we talked about that little in the test taking thing yesterday. They're basically things like skunks, foxes, raccoons, bats. In the United States, bats are the most common exposure. Dog exposure in the US is rare as far as getting exposed to rabies. However, it is the most common cause of rabies internationally is dogs. And the most recent cases that were described in the US were people who had traveled overseas, gotten bitten by a dog or exposed to a dog with rabies, and then got their symptoms here. The reason that happens is rabies lives in nerves, and it travels at about 1 millimeter a day. So if you get bitten on the face and you have rabies, it's a very short distance from your face to your brain. But if you get bitten on the ankle, it takes a while for that virus to make its way all the way back up to your brain, where once it's there, it's a game over deal. That people have survived rabies, but it is so extraordinarily rare, and they don't ever do it normal. There's always some sort of damage done. Rabies is much better prevented. So the key for us to know is when is exposure an issue? So bats are the biggest one. Domestic animals, not usually. Raccoons, perhaps, etc. So what exposure is a risk? And then what to do about it. Okay, what you do about it is you give them the vaccine. So you get the vaccine, and there's 4 doses, but your job is just remember that they get 1. And then if you have the acute bite, they also get immune globulin injected around the area of the bite. As much as you can, the rest gets done at a distant site as far as an injection. So no, you have passive and active immunization, and know that what exposures are the ones that are at risk. All right, snakes. Sometimes they'll throw a snake bite thing in there for you. It's not that common, but it's an area they kind of like to mine. So know that there are 2 types of snakes that are poisonous in North America. They're the pit vipers, which are the rattlesnakes, and then there's the coral snake type, which is a different family of snakes entirely. Red on yellow, kill a fellow. Red on black, venom lack. That particular ditty, that particular little rhyme, is helpful to know if somebody is at risk if they got bitten by a snake. Because there's some snakes that look like they might be scary, but they're not. They're totally benign. It's just you got bitten and it's kind of freaky, but it's not going to kill you. Coral snakes, red on yellow, kill a fellow. So if red stripe followed by a yellow stripe, they're touching, that's the scary snake. When it comes to rattlesnakes, these are pit vipers, okay? So these are basically, they have a pit that detects, it's a thermosensor, basically, the pit viper. They hang out hot, dry places. They're all over the place where I live. They're everywhere, everywhere, everywhere. The envenomate, you can either get bitten and not envenomated, bitten and envenomated a little bit, or bitten and envenomated a lot. And the only way we're going to know which of those happened is by time, what happens over time. The venom itself causes local tissue injury, okay, so it causes damage at the site itself, but it also causes coagulation problems. So what happens when you get envenomated with rattlesnake bite is you get coagulopathies that occur with this. That basically it's a DIC looking kind of picture. You can also get systemic capillary leaks. They can get pulmonary edema, et cetera, with that, swelling that occurs as well. So it has sort of local stuff, coagulation stuff, and some systemic stuff that occur with this. 1 in 4 bites is a dry bite. So our job is basically to figure out, did you get bitten and you got lucky this time? Or did you get bitten and you got some venom and now we need to decide what we need to do about that? The people who get bitten, drunk men, basically, are the ones that get bitten. They just do dumb stuff. And in fact, I have a colleague who saw a patient who got, so they tend to get bitten on the hands, okay, but he saw somebody who got bitten on the tongue. So this guy was drunk, and there was a rattlesnake in somebody's in a cage somewhere, and he went, hey, snakey, 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 and got bitten on the tongue. What an idiot. Honest to God, seriously. There's something Darwinian in that. Honestly, I'm just saying. Say you're out hiking, and you get bitten by a rattlesnake. Okay, they usually do warn you, by the way. Just pay attention to the rattle. They don't want you there. They don't want you there. But if you get in their territory, you're done deal. They may bite you. If you get bitten, a tourniquet doesn't help. So I had a snake bite kit when I was growing up. I grew up in a place where there were rattlesnakes everywhere. We had a snake bite kit. We just went and hiked with it all the time. Turns out it's dumb. So tourniquets don't help. Incision, the John Wayne version, you cut the thing and you suck out the poison, you spit it out. Well, that doesn't work. All that does is gives them a human bite infection later from when you put your Eikenella in the wound that you just made. That doesn't do anything for you at all. That's not a good idea. It turns out what they recommend, I love this, what all of the people that are experts in this recommend is, if you're bitten by a rattlesnake, stay calm and lie down. Have a Zen moment. Are you kidding me? I'm in the middle of nowhere. I've just gotten bitten by a rattlesnake. Are you nuts? It is worth having your cell phone work as a device to locate you because people can find you and use your cell phone, so have that with you. But this little kit does nothing. The key is to know when to use antivenom. Now, a couple of things. If you get bitten by a rattlesnake and it starts to ooze clear fluid, odds are you got envenomated. It's even more important to get yourself seen. The indications for antivenom are progression at the local site. So now those 2 fang marks get swollen, and now the wrist is swollen, and now the arm is swollen. If any of it gets ecchymotic, which means that you probably have had that venom in there that's causing the coagulopathy problem, that needs to get antivenom. Okay, so that's an indication. Any peripheral evidence of coagulopathy, which is a little bit of a challenge, I have to say. If you have some drunk guy who drinks all the time who may be coagulopathic at baseline, ignore that. Assume it's from today's rattlesnake bite. And anything that's systemic, they get antivenom. Okay, there's 2 types of antivenom. Honestly, I don't think they're going to care one way or the other. That they're going to want you to know when to give it. I don't think they're going to want you to know the specifics on this. Do know though that anaphylaxis can occur. Not common, but it absolutely can occur. So I think the key for you on the test for this is know what to recognize is an envenomation and when to go ahead and give antivenom. Know when that's done. So this one, would you give antivenom for this? Got ecchymosis. They're going to want you to give antivenom for that one. Would you give antivenom for that one? If you don't, you deserve to fail the test. Of course you give antivenom to that one. Look how swollen and blistered it is. That is nasty business. So that's a rattlesnake bite that gets treated. Coral snakes are different. So the coral snake, they don't like to bite you. Okay, we see vastly more rattlesnake bites than we do coral snake bites. Probably because there's so many more rattlesnakes, to be honest. These bites are uncommon. Okay, it's less than 1%. But this venom is neurotoxic. And this venom takes a while. So this is, you get bitten, I think I'm okay. You go home, 4 hours later you're sitting, or 8 hours or 10 hours later you're watching TV, and the bite's not bugging you, but you start to feel a little confused, and you get paresthesias. Things aren't feeling right. You got envenomated. Okay, usually this is supportive care. Rarely in bad envenomations you'll go on to get true respiratory failure and need to be intubated. Most of the time you can just kind of watch them. Antivenom is not often available for this, so supportive care becomes even more important. There are certain places you can get it. I tell you, if you ever have any weird stings or bites from critters, call your local zoo. Turns out the zoo has a lot of access to both the antivenoms and the things you treat with, and a lot of places to send you if you need some of this stuff. So your local zoo turns out to be helpful. Spiders. Black widow spiders are everywhere. Okay, they like dry spaces, they like wood piles, etc. They love them. Brown recluse spiders are not everywhere. They tend to be very localized in certain parts of the country. Here is a list of the two lists to compare the two. Black widows are nasty and aggressive. Brown recluses are named appropriately. They don't come after you. Black widows are mean. They're just mean. They will come after you. They're mean. They have the hourglass. They're jet black with this beautiful hourglass on them. It's the female. She's already consumed the male and done away with her husband. It's the female. And they are out in your outhouse. I had one in my our irrigation system, the little cover on it, I popped it open the other day and she's just sitting there up in the corner. She is now pulverized. She's like in submolecular particles somewhere. I pulverized her, but she is long gone at this point. But they're all, it's often where you're reaching to get something. You want to basically, they're in there and they bite you. So they're aggressive, and when they bite you, it hurts when they bite you. It's not, you know you've been bitten, okay? It hurts, for one thing. And if you get the venom in your system, what it tends to cause is nausea, vomiting, and abdominal cramping. And if people don't know they were bitten and they just come in with that, they can look like an acute abdomen or appendicitis. They can look like an acute abdomen. The key is to track it back to the exposure itself. All you usually do with this is ice, some opioids for pain. The calcium issue is not something that's accepted well enough to be on an exam, so that's not going to be there. And antivenom, although available, rarely used. Mainly it's kids. Okay, kids are the place you'd use that. Brown recluse is a little different. The wound it doesn't usually hurt when you bite, but within a relatively short amount of time, 12 to 24 hours, you get this volcano lesion. I'll show you a picture. And that toxin, when it gets into you, causes basically microangiopathy. So the people that get brown recluse end up losing limbs. They end up with basically, it looks like a meningococcus patient. Okay, they end up losing limbs. There's no way to treat this. Dapsone maybe, HBO but mainly maybe, but it's kind of bad news. So the brown recluse bite, when it starts to give you trouble, looks like this. That could be disseminated GC. But then what it does is becomes this little volcano. That comes out of the middle. This is the volcano, and this person may develop microangiopathic symptoms. Eventually, it can cause pretty bad breakdown locally as well. So it's actually significantly worse if you get a brown recluse bite that's bad than is a black widow bite. Bees, wasps, and ants. If you die of a bee sting, you die now, and you die because of IgE, and one sting can kill you. That is a true allergic, sort of IgE-mediated bad news, all things go to hell kind of deal. That's why you need an EpiPen if you're really truly allergic to bee stings. That causes true anaphylaxis. You can, however, if enough bees get mad at you and you get stung by enough of them, the venom itself can cause trouble. Some 94-year-old guy in Redondo Beach got bitten by basically what turned out to be probably Africanized honeybees. He got bitten more than 900 times. He got bitten 10 times his age in bee stings. Poor guy, he survived, God bless him. But that's enough of a load that the actual venom itself can cause you trouble. So just know that, and they're not more lethal, they're just madder. So Africanized honeybees, Africanized bees aren't more lethal, they're more likely to sting you in groups. So they're not worse for you, they just are meaner. So this is this poor guy. I mean, look at this. The key to getting these off, by the way, is pick them off. Okay, get your tweezers and pick them off. You don't want this to actually activate. You want to pick these things off. You're going to be there a long time for this guy. This table and this next one are two ones you should go back to before the exam. One of the things they like to ask on the exam is, which of the following are transmitted by mosquitoes and which of the following are transmitted by ticks. You just need to know which are which. I'm not going to drag you through it. You can go back and review this later. All right, last little bit, marine envenomations. If you love to swim in the ocean and you've been there a lot, especially certain parts of the world, you have been bitten by these guys. You've been stung by these guys. It's a nematocyst. It's a very clever little device. It's like a little gun that they jam the needle part into your skin and then it squirts the venom into you. Bad news, the deadliest of them is the box jellyfish. That's worth knowing because that's a testable item. It causes a respiratory arrest. The toxin in this causes a respiratory arrest. If, however, you get envenomated and you're at the beach somewhere and you've gotten draped with a Portuguese man of war and you've got all the stuff that goes with it, what you want to do is, first of all, don't rub it. You'll activate those nematocysts. Pick them off, or better yet, take a credit card and scrape them off. Try to get them off while they're still intact. Consider the hottest thing you can tolerate liquid-wise, and consider something like vinegar. That may help as well. There's a lot of debate about whether these all work. The key is hot water, not cold. So consider hot water. That may help. And consider using something like vinegar. Coral cuts are prone to infection, just know that. They burn when they start, and they often will itch. They can cause a histamine reaction, so antihistamines may work. Watch them for infection down the line. And the bottom line is, don't touch coral. It's growing, you're not supposed to, but if you do get cut, that's what can happen. Oops. Stingrays. Stingrays kill you one of two ways. Stingrays killed Steve Irwin by basically stabbing him in the heart. Okay, Steve Irwin, the adventure guy from Australia, got stabbed literally in the heart by the stingray's barb. And it has a barb. It gets hooked in and it can't come out. It just goes in there and gets hooked in. It also has, though, a toxin. And that tends to cause flushing. It's almost like a disulfiram-like reaction. You get some diarrhea, some cramping. It's almost like disulfiram. The key to these is hot water as hot as you can possibly tolerate, and then getting that thing out is tough. It has a barb on it, so you may have to do some cutting down to get that thing out if it gets in there. There's some marine infections that you can actually wrap up with here yourself. Take a peek at some of these. I don't think they'll get into these. They sometimes like to get into it. Overall, just take a peek at these later for your edification. And that is the end of this.